while Aron is setting up then the computer and the presentation, so let me introduce him. First, it's really my great pleasure to have Aron here. So Aron is a medical doctor and he's PhD and consultant, spine surgeon. He's deputy director of the National Center for Spinal Disorders, and he's a professor at the Semmelweis University in Budapest. I will not go through his whole CV, but just a few words. I'm very happy to have Aron here because many years ago, in 2012, if I remember correctly, so Aron and I participated in a European project, and that was aimed already to combine clinical data about low back pain and surgical treatments of low back pain with numerical modeling. And I think it was a new venture, both from Aron's side, who basically then came to know finite element modeling and computational analysis, and on sides of people like me, who are modelers, who came to know the clinical reality. And we had to start to talk. We had to start to learn to talk different languages. So I, the clinical language, and Aron, the engineering language. And I think it has been a great success story because now 10 years after, actually, Aron is here and to present finite element studies, so coupled with real clinical cases. So it's a great pleasure to have you, Aron.
Thank you very much. Yes, Jérôme, you're absolutely right that I think my spine was the most important project in my scientific career because it opened a lot of new ways for us. And thank you for the invitation. It's a big honor for me. And I try to show some of these new ways where clinicians and engineers can work together on solving real clinical problems. First, why I am a spine surgeon, or why the spine? And we can say that spine problems are really common in world, and actually this map can show you the countries in purple color where spine and especially low back pain cause the most disability in these societies. So it's low back pain, degenerative problems of the spine are really common and causing a big economical and health problem. On the other hand, spine is, I think, the most beautiful organ where biology, biomechanics, and pathologies and symptoms are really close related to each other. And from the molecular level to the organ level, you can find a lot of connections, a lot of relationships. And when we are treating the spine, the spinal disorder, somehow we can influence not only the organ level or not only the disease itself, but also the whole body. So that's why I think it's a really complex and important field of surgical medicine. And the real answer of the question, the personal answer, is that my mother had a spine surgery when I was young, and I realized the effect of the surgery on the pain. So that's why spine. And more than 10 years ago, when I joined the team of the National Center for Spinal Disorders in Budapest, after getting the PhD or doing the PhD study in molecular genetics, I realized that in clinical, everyday clinical life, there are a lot of problems, there are a lot of questions in spine. What cannot be solved cannot be answered with actual tools. And for example, one problem was with these huge surgeries where the whole sacrum is resected because of tumor, and you have to somehow restore the the biomechanics between the lumbar, rest of the lumbar spine and the pelvis. You can imagine that if you remove the whole sacrum, there is a big gap between, biomechanical gap too, between the lumbar spine, the trunk, and the lower extremities. So there were different possibilities using implants to restore this kind of, to solve this kind of biomechanical problems. But we didn't know which kind of solution, which kind of implants, which kind of constructs are the best or are good. So, and exploring this issue, I found a quite old paper about this question, the lumbar pelvic stabilization using finite element modeling. And that time, I only realized that pictures are very nice, colorful pictures. And with using this research technique, they can answer something which is important in the clinical life. So I realized that this is something that we should do. And on the other hand, I realized that we can't do that time. I was nothing background about modeling or mathematics or something like that, and I didn't have the people to do that. But that was the plan. And some years later, actually more than 10 years later, just recently we published this paper with our lab about the solution or about the answers on the lumbar pelvic stabilization using the finite element modeling. So actually my dream came true, but a lot of effort and and I was actually lucky with that road, but it was quite difficult, and I will try to show you some milestones of this road. Finally we get this kind of publications and analysis in our hospital actually. So you all know that finite element analysis is a quite old technique in musculoskeletal systems, but from the very beginning to the sophisticated models, as I feel there is a big difference between a single bone like the femur and the spine, that the spine is quite a complex organ. And this slide was done one of our PhD students, so I will show you that how an engineer imagine the spinal anatomy as in a nutshell. So spine should provide the structural support, enable flexible motion, and protect the spinal cord. These are the three main functions of the spine in the human body. And to do that, we have this column of the vertebrae and discs, and we have the motion segment, which is the composition of two vertebrae and joining tissues, joining organs like the disc, and also the ligaments are very important in the spinal anatomy, and the facet joint at the posterior part. And in the spinal segments in the center, there is the spinal canal, there is the spinal cord and the nerve roots. Regarding the whole structure of the spine, we have different kind of parts and shapes or alignments of the spine. We have the cervical lordosis, the thoracic kyphosis, the lumbar lordosis, and the sacral. At the sacral part, there is also kyphosis of the spine. And the development, these curvatures, is really dependent on the motion development of the baby. So here you can see the parts of the spine, the segments, and here you can see the composition of a vertebrae. You all know that there is the cortical bone and the trabecular bone inside, which is not only important from the biomechanical point of view, but also this is one place where the blood forming in the body is happening. And the end plates, the bony end plates and the cartilaginous end plates are very important in the nutrition of the disc. The disc itself has got these two very important parts, the nucleus pulposus, which is a jelly-like component, especially in healthy condition, and the annulus fibrosus composed by multiple layers of fibrosus tissues. And also the cartilaginous end plate. From the biomechanical and also from the biological point of view, the cartilaginous end plate are parts of the disc. So the finite element analysis of the spine has got also a quite long history, started with this gentleman and the work of his group describing the first or most important associations in the biomechanics of the spinal segment and the different parts of the spine, followed by the development of the first multi-segmental spinal finite element model. And here you can see it was quite complex. It was published 20 years ago. And now we are in the era where a lot of questions can be answered with the finite element simulations. Marco Viceconti had some very important, actually keynote papers about the importance of in silico science and in silico biomechanics. And in a very early paper, he emphasized that the model what we used and the type of the model what we used in numerical simulations are very important, because we have to use the proper model to answer the question. And the accuracy of the model and also the limitations of the model are very important when we want to answer a question properly. Some years later, he also emphasized that the biomechanics is a field of science where the living organism can be studied as mechanistic systems. So it can change a lot of things in the, actually it's changing a lot of things now, and it will change a lot of things in the future, because a number of diseases or even healthy conditions can be described and can be understood as mechanistic systems. That's why the process of clinical trials, when we test new medical methods, new implants, new drugs, are under the change. I mean that some years ago, the era and the method or the possibility for doing in silico clinical trials have been established. And now there are some methods, there are some models, there are actually some new treatments which were proved, the efficacy and the safety of the treatment were proved in an in silico environment, and not in vitro or in human or animal studies. But the in silico trials were very important in proving the efficacy and safety of the new treatment or the new method, diagnostic method, for example. Regarding the cost effectiveness and also the possible harmful effects of the clinical trials, we can expect for a widening of the scope of the in silico clinical trials in the future. So in some years or decades, most of the clinical trials and most of the tests will be done first in silico environment, and maybe in some cases that will be enough, the in silico trials to introduce or implement new treatment methods and diagnostic methods. But to do this kind of studies, we have to choose the best tool. And you all know that if we want to magnify something, we have different kind of tools. But to choose the proper one, to magnify the field of interest is a crucial question. That's why we formed the so-called in silico biomechanics laboratory in our hospital. National Center for Spinal Disorders is a hospital. But now we have a biomechanical laboratory where only computers can be found and people who can understand the computers and the tools. But because surgeons have a lot of questions, and we face a number of difficult cases, a number of unanswered questions, especially in spine surgery. So we have a quite huge clinical experience on difficulties in medicine, and we wanted to answer this kind of, or respond on these difficulties with the tools of science. So that's why the operational environment of the ESBL, the in silico biomechanics laboratory, is some kind of scientific activity based on the clinical experience. So a lot of input is coming from the everyday clinical life, and science can respond or try to respond on this kind of clinical problems. And our strength is in the people who are in the lab. And I want to highlight Peter, Dr. Peter Éltes, who is actually a spine surgeon, but he's also a biomechanics and did this VPH summer school about 6 years ago. So it's this kind of training is very, very good, I can tell you. And among the 4 active PhD students, we have 2 doctors and 2 engineers. So now also engineers are in the hospital. Dangerous. But they can be very, very, very active and good guys. On the other hand, I also want to acknowledge the other research staff. For example, when you are dealing with patients, you need personal contact with them, and we have study nurses who can collect the data from patients. And in my life, I saw some very good projects where the problem with the project was that between the scientist, engineer or doctor, and the patient, there wasn't anybody who could somehow transfer the questions, the data, the problems, the answers, and so on. So research staff, especially study nurses, are very important. And they have also about 20 spine surgeons in the hospital, and we can get not only the data from them, but also some important questions, some important field of further studies. And I also want to acknowledge that the external partners, they are scientific, academic partners from different countries, like the UPF, like Jérôme, and also some partners from the industrial field. And I can tell you that without this partner, we couldn't do anything. And here I want to emphasize the importance of knowledge transfer between different partners and different fields of science and clinical and basic science. Among our research topics, there are projects focusing on spinal pathologies. There are also some projects where we try to improve the diagnostic tools, and also we are trying to support the decision making on the treatment of the patient. And finally, we also try to support the actual surgical treatment of a given patient, or we try to explore differences or important issues with different kind of surgical treatments. I will show you some examples on that. And the tools that we use in the everyday life is detailed image analysis, 3D modeling, 3D printing, finite element analysis, and we are also considering the possibilities in the automatization of different steps, the use of artificial intelligence in the different projects, and somehow we have to be quite specified for the given patient. And this can be quite time-consuming and can be a little bit difficult to spend a lot of time, money, effort to solve the problem of only one patient. But the knowledge coming from this kind of projects is invaluable. Regarding the model complexity, I can't tell you a better expression than Albert Einstein did, that try to make everything as simple as possible, but not simpler. So to find the, as I told you, to find a good level of complexity or simplicity, on the other hand, is important in the implementation of a project. Otherwise, there can be two big problems. One, that you can't find the answer if the model is too simple. Or the other one is that your answers or the results will be too difficult and very far from the understandable level of everybody. Because don't forget that the science is not for the science. The science is for the people and for the society, for the community. So any kind of scientific results should be communicated, should be transferred, should be disseminated, and sometimes in the level of very common people, like politicians, for example, to get the final result. And in our life, as Jérôme mentioned, the MySpine project was a milestone, because that time we were very lucky and very happy to meet bioengineers, high qualified scientists in this field. And we were involved into the project as clinical partners, but we tried to learn from each other a lot. And I think that time personally me, I was happy to realize that these kind of simulation techniques and finite element analysis can really answer spine-related clinical questions. For example, such as the degeneration process of the disc in time, or the future changes in the bone density of the vertebrae after different kind of surgical solutions. So for us, it was a very big experience to be involved into this consortial European project. And after that, we try to follow the way and realize some own projects. And one very important issue is also the possibility of the patient specificity. So when you are studying bone, you can map the patient's real material properties based on the CT. For example, it was first described in this paper with the first published patient-specific vertebral body finite element model, where the colors are reflecting on the actual bone density at that spot. So we are able to do that. Sometimes it's necessary, sometimes it doesn't. It isn't necessary to do the patient-specific modeling. But for example, in the next project, or the first project that I want to show, that we used this kind of approach to simulate and to find the association between the pathological fractures in metastatic patients. Because not only this degeneration is a big problem, but also the number of patients with spinal tumors is continuously increasing, because there are more and more people with living with a longer history of malignant tumors, lung cancer, colorectal cancer, breast cancer, and so on. And with time, the appearance of spinal metastasis actually almost always happen. So we expect for more and more people with spinal metastasis, and it can cause a real clinical problem, and a lot of problem is associated with the fracture of the affected vertebrae. So in this project, with the laboratory of the Sheffield University, we analyzed the association between the metastatic bone, the metastatic vertebral body, and the risk of fracture and the material changes of the material properties of the vertebral body, the changes of the biomechanical properties. And we did that because in everyday clinical life, it's very important to somehow figure out the chance of fracture in a given patient. And there is a clinical tool developed about 10 years ago. It's a SIN score, Spinal Instability Neoplastic Score, developed by the EOSpine. And the SIN score is a very simple system for clinicians. It's a scoring system based on the clinical and radiological appearance of a spinal mat. And using this scoring system, you can define the risk of instability for the given patient, for the given metastasis. And this is important in the clinical decision because if there is an unstable lesion, to protect the patient's neurology and to decrease the pain, you need to make a stabilization surgery, which can be quite a huge surgery, especially for the patient. So SIN score is some kind of clinical guidance, clinical tool. And in this biomechanical project, we were really interested about the association of the real biomechanical properties of the affected vertebral body and the SIN score of the patient. And in one hand, we found a very nice association between the metastatic lesion, the appearance, the type of the metastatic lesion, the amount of the vertebral involvement, and so on, and the biomechanical properties. On the other hand, actually, we didn't find any association between the SIN score and the actual biomechanical properties. So after this investigation, we concluded that the further development of this kind of clinical evaluation tool would be necessary to make a stronger relationship between the real biomechanics of the vertebra and the clinical scoring system. Maybe in the future, an application or a smartphone tool will help the surgeon to really model and assess the actual fracture risk in a metastatic patient, considering the real biomechanics based on the CT, for example. But now we don't have this kind of tool. We have very sophisticated patient-specific modeling tool, which is time-consuming, takes a lot of energy. It's not realistic in the everyday clinical life. There are only a few hospitals with supercomputers and so on, computing facilities, and those are engineers. On the other hand, we have a clinical tool which actually doesn't reflect on the real biomechanical issues. So this is a way for the future improvement. On the other hand, we had some success stories. For example, regarding the surgical planning, when a difficult case should be treated surgically, but the surgical treatment can be quite complex. For example, in this patient, you can see that the patient was operated previously with a lumbar fusion, but it was not a success story. Actually, the patient had 7 spine surgeries over a 40-year period. So multiple surgeries, and these are not really rare. We call that failed back surgery syndrome. And this is an old patient in high level of pain, in high disability, with significant comorbidities. But we know that in this kind of situation, what you can see on the X-rays, only the surgical treatment can help. We call that post-op flat back deformity. And the patient had different source of pain. For example, the malalignment of the lumbar spine. You can see also on the MRI, that the lumbar spine is straight. The patient lost the lordosis because of the previous surgeries and the previous bad stabilization. On the other hand, there is also adjacent level degeneration causing spinal canal stenosis and nerve root compression and so on. So we have different problems to address, but one of the key problems is the malalignment of the lumbar spine. And we know that only the surgical treatment can help, and the goal would be to treat all the spinal pathologies, also the alignment. So we have to somehow correct the alignment of the spine, but correction of such a deformed spine with a rigid deformity can be done only via some osteotomy. So we have to resect some part of the spine to realign that. So we had some questions to the bioengineer that we asked her to help to understand the complex pathology, to understand how much alignment correction is needed for the given patient and what kind of osteotomy should be performed. Here you can see the basis, the scientific basis of the investigations. This is the spinopelvic alignment and the global balance complex. So spine, the whole spine is one system, and the whole spine can be characterized by the alignment and the balance of the body. And there are a lot of radiographic parameters describing this alignment and balance issue, and every patient can be analyzed in terms of this alignment and balance descriptors. Here you can see the evaluation of this patient. The patient had a pelvic incidence of 55 degrees. On the other hand, the lumbar lordosis was only 17 degrees. Based on the previous clinical studies, and this concept, the global balance concept and the thoracolumbar alignment concept is about 15 years old. So you have a lot of clinical data supporting this concept. And from the data, we have some formula from the clinical studies. And using these formulas, we can calculate the ideal or the optimal alignment values for the given patient. For example, in this case, the optimal lordosis of this 71-year-old patient would be around 40-45 degrees. And there are other parameters also. For example, the SVA, this red line, which is the distance from the sacrum, distance between the sacrum and the C7, the cervical 7 vertebral line, plumb line. So the SVA should be also decreased to correct this kind of alignment. Okay? So the surgical goal would be a lordosis correction of about 20 to 30 degrees. It's not. It's quite much, and we have 3 places to do that because we had to do a fusion at L1 and L3-4. So above and below the former fusion, we had 2 bad discs to treat with fusion, and at L4 we also had to do an osteotomy. This is the PSO, the pedicle subtraction osteotomy, where the 2 pedicles and a shape like this is cut from the vertebral body, and we can close the vertebral body to the back. So with this maneuver, we can realign the lumbar part, making more lordosis than before. And to realize this plan and realize this surgery, we used first the virtual models of the situation, and we also printed out the actual situation, and it was really helpful for the surgeon to understand. Actually, the surgeon was me, but it was really helpful. Now, originally this patient, and it was a good experience. The patient was a patient of an older surgeon, a really guy at the end of his career, 65 years old. But he was really open to learn something new. So I remember the time when we gave the model to this old guy, and he was really happy with that to have in his hands. So it was useful. But I assisted and helped him with this complex surgery. And we also were able to simulate the osteotomy in the virtual environment. So before the surgery, we planned the osteotomy using the virtual model. And here you can see, here you can see the plan for the osteotomy here. And this is the situation after closing the osteotomy. So we cut this part of the bone, and after that we close the gap, and we have a new realigned lumbar lordosis, okay? So finally, after the planning, the surgery was quite successful without any complication. And during the surgery, we also used the printed model to understand the actual situation. And the patient was discharged after a quite short time after this huge surgery. Here you can see the result. So you can see that a lot of meta we use. We always use a lot of implants or a number of implants, sufficient number of implants, screws, rods, and so on. But the osteotomy is here, you see, from this vertebra. And the lordosis, lumbar lordosis changed a lot. In numbers, finally, the lumbar lordosis was 47 degrees. And the SVA, you can see this distance with the red line, the SVA decreased. So the global balance of the patient changed a lot. There is a gap score, which is a very useful score to characterize the global balance, the global alignment proportion score. And the gap score decreased significantly from 8 to 3. And right after the surgery, and it's very, very nice to experience that even after a huge surgery, if the balance is better, the patient experience right after the day after the surgery that he or she feels much better. So the pain and the disability indexes decreased a lot. And here you can also see that this PSO was asymmetric because we wanted also to realign the spine in the coronal plane. So this is the coronal alignment. So we were able also to publish this as a case report to emphasize the importance of patient-specific surgical planning using 3D models. On the other hand, we have other clinical questions where patient-specific models are not required. For example, to answer that, we developed a two-segment model with full of these discs and ligaments and so on. And there is another procedure, the OLIF procedure. There are a lot of acronyms in spine surgery. The OLIF means oblique lateral interbody fusion. So we are doing a fusion procedure between the vertebral bodies, but we reach the disc from an oblique way through the transperitoneal space. Behind the peritoneum, behind the abdomen, there is a space which is quite huge in fat patients, for example, full with fatty tissue. But it's quite safe because there is no major vessels and no major structures, especially in virgin cases. So it's a good and safe environment to approach the disc. Actually, for the spinal fusion, for the lumbar fusion, which is the procedure when we connect two or more vertebrae and we introduce a bony connection, a bony fusion, which develops about in half or 1 year. But it's a quite routine procedure or basic procedure in spine surgery. For the lumbar spine, we have a lot of options, from posterior, from the side and also from anterior, we can reach the disc, because the disc would be removed to place the implant and to place the graft to stabilize and fuse the spine. So OLIF is one of them, and actually I really prefer this procedure because it's quite different from the posterior procedures. It's a minimally invasive procedure, and we have quite good clinical data. On the other hand, I'm sorry. Here you can see the result of a single level OLIF. This disc between L3 and 4 was really degenerated with the collapse of the segment, and the huge implant was placed from the oblique approach inside into the disc space, and after that, from percutaneous procedure, some screws were introduced into the vertebral bodies to make a proper stability. And we started this procedure about, I don't know, 5-6 years ago. And sometimes there was a debate among the surgeons about the need of this additional screwing. Because it's time consuming. The surgery is started on the left side or the right side. After that, we place the implant, the intervertebral cage. After that, we turn the patient onto the belly, and the screwing is doing from the posterior. So it's in prone position. Actually, with a good team, the turning procedure, it's about 10 minutes or 15 minutes. But you have to need additional implants, additional cost, and so on. So there was a debate among the surgeons. Is it necessary? Or maybe from the side, we can put a plate onto the vertebrae with screws, or maybe nothing, or maybe a new implant with screws inside a standalone cage would be very important. We don't know. And finally, the lab and I was fed up with the debate, and we did this kind of simulation study about the different additional stabilization constructs. So here you can see the conventional one with screws and rods, a lateral plate. This is the second, and the third one is a so-called standalone implant. The plate is physically attached to the cage. And we simulated two different conditions, a segment with healthy bone and a segment with osteoporotic bone. Because this oblique fusion, OLIF procedure is the best for aged people. I mean the best that the loading of the procedure on the patient's body is more advantageous in aged people, the minimal invasivity of the procedure than compared to a young one. But in aged people, bone quality is often compromised. So we simulated also the osteoporotic condition using this general model, and we found that the strains and the stresses, these are the stresses on the end plate is really different in case of the different kind of stabilization techniques. And this can be associated with the implant loosening and the subsidence of the cage. So the long-term success of the surgery is really related to the type of the additional stabilization. So finally, we concluded that especially in case of osteoporotic bone, aged people, the need for the additional transpedicular posterior screw and rod fixation is essential. So we closed the debate. On the other hand, again, when or how complex models should be used to answer different questions. Here you can see a study about the complexity of different models and the consequence of the complexity. The first, or the left, on the left part, this is the anatomy is patient specific. It was a healthy spine. It was from a healthy spine. The lumbar anatomy is real, and the anatomy is the same, both cases. But the material properties were assigned in first case based on the literature, and on the second side based on the patient CT. So on the right side, you can see a real patient-specific lumbar finite element model in terms of the anatomy and in terms of the bone material properties, not the disc. Disc is general. And you all know that there is a huge difference between patient-specific bone mapping and compared to literature-based one, and the model complexity is very different in the two cases. And comparing after that, the simulation results showed that actually in the range of motion or in the forces, there are no real differences between the two models. But the simulation, the computational time is really different. So if you choose real patient-specific models for every kind of questions, for every project, you have to count with an enormously high computational time. And we can see that often it's not necessary to use real patient-specific models. We can use very good general models, literature-based data, to answer clinically important questions too. And it's very important. For example, and I was happy to see that one of the posters outside is about PGK. Okay? Proximal junctional kyphosis. And I saw that Ferran Pellize is among the authors. I can tell you that he was one of my tutors. I spent 1 month in his hospital some years ago to learn about adult deformity surgery. And he's great. So, proximal junctional kyphosis appear when the patient had a previous fusion, especially a long one, and the segment above the stabilized spine have a fracture or have a severe kyphosis because of degeneration and so on. And this is quite common. And unfortunately, it means a real problem, especially in long fusion. Here you can see that the cascade of the PGKs, the subsequent PGKs, resulting finally a very long construct from the ileum to T2 or 3. So all the thoracolumbar spine finally will be stabilized, will be rigidly fixed. And sometimes we have to go to the occiput to somehow treat the PGK problem. And we know that the PGK is related to the alignment, is related to the global balance, but can be also related to the type of fixation. And some kind of preventing fixation techniques can be implemented during the surgery to prevent PGK, but we have no data, or we have very limited data about the biomechanical issues related to these preventing surgical techniques. So to answer that, we developed the thoracolumbar model. It was a general model, and we developed the finite element model of different preventing possibilities of PGK. The original surgery was a long surgery, a long fixation with screws and titanium rods from T8 to L5. Okay, this is the original surgery, or the original scenario. And we were thinking about the prevention of the PGK, of the development of PGK above the upper instrumented vertebrae, T8, thoracal 8, using some kind of different rods at the end, at the upper end of the fixation. And in this case, we used a connection between a PEEK rod, which is, you know, a plastic, some kind of plastic material. So the PEEK rod is going from below to the upper instrumented vertebrae. This was the second scenario, and the third one was a titanium but a multiple rod system. This multiple rod system was originally the invention of my former boss, Dr. Peter Varga, and we used that for, especially for aged person to avoid screw loosening, because the idea was that this kind of multiple filament, multiple rod system can give some micromotion in the segment. It was never proved. It was only the idea of Dr. Varga, but a lot of patients was treated with this concept successfully. So our idea was to use that to prevent the PGK. And here you can see the results of the simulations. In one hand, the stress on the upper instrumented screw was absolutely lower in case of PEEK and the multiple rod system construct. So the stress on the screw. On the other hand, the range of motion of the upper instrumented segment was higher in case of this kind of constructs compared to the titanium stabilization. So it can suggest that at the end of the construct there is more mobility. And some mobility can prevent the overloading of the adjacent segment. Okay, this is the theory. We don't know that in real life it will work or not. But this, from the biomechanical point of view, this is a technique what can help to prevent the PGK. And the results were quite good that we had to patent this connector between the titanium rod and the multiple rod system, because this is not on the market, and somehow we try to protect our intellectual property. And this is a very important thing, will be in your life too. The results of your science, the results of your scientific activity can provide some intellectual property which should be protected. Because especially in spine, the business is quite huge among the implants. And almost all of the implants are developed by engineers. The spine surgeons can have some idea, but 99% of the ideas are bullshit. But the engineers will show what idea can work. They will design the implant, so they work a lot. But finally, especially in the US, spine surgeons get the money from the implant. So in the future, if in your life, it would be very important to protect your intellectual property. And it's a process, it's very boring and very time-consuming, but it can be very important. On the other hand, the scientific publication always a goal for scientists. So we have submitted that. I think that we will see, but it's also important. And we have to talk about the more complex models. But I can tell you that sometimes these more complex models, focusing on the whole body, on the whole trunk, on the whole body level, and also containing muscle forces, patient-specific gait, patient-specific loading conditions, are too complex to handle, too complex to really use in the everyday life today. But we'll see in some years that more complex models will be available for more and more times. Actually, this is a publication by Fabio's team about the use of gait analysis for patient-specific loading conditions. And it's something which is important, but to realize that in the everyday life, it's not easy. You can see that how difficult can be to get the gait analysis data. And actually for the spine, there is no gold standard protocol. So all of these analyses are some kind of estimations, but can be implemented to the whole body model. And finally, we can have a patient-specific loading condition on each vertebrae, for example. But maybe the questions where this is important, the number of questions are limited, very limited. Actually, with the patient or with the problem with the lumbopelvic stabilization, you remember, it was a long time ago, but we made a gait analysis of the particular patient, and we also published as a supplement that how the gait of the patient differ from after time. After some time of the surgery. And the protocol was a simple but useful protocol was developed by foreign PhD students. And we also applied this protocol for fusion patients, for more common patients. And we can see there, in case of longer fusion and shorter lumbar fusions, there are differences in the motion of the segments of the body. And we can also see some differences in the motion of the segments according to the success of the surgery in terms of the global alignment, for example. But the real clinical value now it's unknown, unclear. I want to show you another everyday experience with the use of 3D techniques, and this is about surgical planning and the execution of different difficult surgeries. And this is a case with a young patient who had a very severe leg pain. And actually, this patient had a discectomy, removal of the disc herniation because of the leg pain, but the leg pain didn't disappear. And the new MRI in our hospital, the discectomy was done elsewhere. A new MRI in our hospital showed that there is another reason of leg pain, and it was a tumor. It was a big tumor in the lumbosacral, in the sacroiliac area of compressing the sciatic nerve and so on. This tumor was, here you can see the CT images of the characteristic of the tumor. Based on that and then on the biopsy, it was a chondrosarcoma. Chondrosarcoma is a malignant tumor with limited options for chemo or radiotherapy. So only the resection, the removal of the tumor can cure the patient, and the resection should be done in one piece. This is the en bloc resection of tumors, when we removed everything in one piece with healthy margins, tumor-free margins, okay? And these are the most difficult surgeries in spine, and we need a very good plan to execute the surgery. And years ago, I have only my own tools for planning. I used the MRI and CTs and tried to plan the level of or the planes of the resection, and I also had some drawings to plan and understand the pathology and plan the reconstruction technique with implants and so on. But now we have the 3D printing technology, and we use 3D printed models for planning and for understand the situation. And not only before the surgery, but the model is in the operating room. And during the surgery, we always ask the nurse or the assistant to rotate the model to see where is the bone, where is the resection, where we are actually. And it's very useful. Now we are conducting a survey study among surgeons on the usefulness of 3D printed models in the surgical procedures to establish the importance. And here you can see the result. So actually the planned resection was done with the use of this model. Or also the 3D techniques can be used for navigation. Navigation of resections, navigation of implanting screws, rods, any kind of implants. And one technique which can be used is the designing of surgical navigation templates, first virtually, and after that you can print it out. And for example, this template was used for the resection of a tumor like that, like the previous one. Here is the resection plane, and we used that during the surgery. This one was used for the implantation of quite difficult screws into the sacral bone. And with this project, you can see two different channels. And on the patient-specific model of the patient sacrum, we determine the best way, considering the bone quality of the different way or the different trajectories of the new screw. So we published that because this was the first when the surgical navigation in spine considered the patient-specific bone material properties to implant something. And my last topic is about the difficulties, because when we want in the future, if we want to perform clinical trials using finite element models in spine, we need really good models. And a recently published paper showed that spine is quite complex because it's not a rigid body. It's the alignment and the motion of in different angles can really influence the biomechanical properties of the spine. For example, if the same model or the same spine is in different alignment regarding the lumbar lordosis, you will have different stresses on the discs. You will have different moments and forces on the spine, on the parts of the spine. So it's important. And the problem is that the detailed imaging methods that we use for modeling for purposes are done in supine position. CT, MR, patient is lying. But loading, everyday loading is on standing position. And only the X-ray, there is a standing MRI, but absolutely not widely used. So X-ray is in standing position. And for example, here you can see the same patient's pictures in different, from different modalities, imaging modalities, and in different positions. So we should somehow solve the problem that the data for modeling coming from the CT in supine positions can be really different from the data in standing position, in everyday, where the everyday loading is realized. And we calculated, for example, based on 50 patients, this difference is in the lordosis angles between the segments and the total lordosis. So the mean difference between the total lumbar lordosis between standing and prone position was more than 5 degrees. And it can mean a lot in biomechanics. So we try to develop a method for the transfer function, for adapting the CT-based models to the standing position of the patient. And here you can see that X-ray, using X-ray, we have two different angles. And from the two different angles, we are able, with using some softwares, to develop the 3D, not to develop, but to match the 3D models of the vertebral bodies to the X-ray shapes. So from the CTs, we had the 3D models, and the 3D geometries were adapted to the standing X-rays, using the different angles and the softwares. And we also calculated the reliability of this procedure, this matching procedure, using different raters, different researchers. It was quite reliable. And if you had the standing adapted the adapted 3D model to the standing position, we made a virtual X-ray from this new model. Here you can see the virtual X-ray, and the virtual X-ray, the lumbar values, angles were calculated, measured, and we compared these measured values to the actual values from the X-ray. Okay. So the real X-ray of the patient was compared to the virtual X-ray coming from the standing positioned CT. And here you can see the differences. The blue bars show the difference between the virtual X-ray and the actual real X-ray, and you can see that the differences was below one degree. So the method was quite good in terms of having the standing position of the patients, adapting this position to the CT-based model. This is under publication, and I hope that we will be able to also show the importance of that on the biomechanics. So we will use in the near future, we try to use 3D models coming from the prone position CT, but adapted to the standing position of the patient. And the difference will be seen. Will be clear, maybe there is no difference. So in conclusion, I can tell you that in silico techniques can help to solve a number of clinical problems, especially in spine. And the best if the in silico techniques are incorporated into the clinical life or into the hospital life. Because in that case, the surgeons, the clinicians, and the scientists can communicate to each other every day or every week. So it's a living communication, which is very, very important. I previously mentioned the Genodisc project, where we published this kind of editorial paper about the need of communication, relationship between the scientists and the surgeons. So that time we realized that if scientists, engineers work apart from the surgeons and vice versa, the questions won't be resolved. Working together, this is the only option to really reflect on the problem of a lot of people. So that's why we try to make a bridge between the medicine and engineering in our lab. And thank you for attention.
Thank you so much, Aron, for this great talk and this fantastic example of integration of engineering into a clinical setting. So, do we have questions? Yes, over there, eggs.
Just a brief question about the imaging. Do you know what kind of staining agent was used for the CT scans?
Sorry?
Staining agent, like for the CT scans.
Fluoroscopy, for example.
It's...
We don't use anything routinely. For the CT?
Yeah.
No. There is no any...
There is no staining at all. It's just...
no.
Because
okay. Why? Because of the colors?
Yeah, because I've seen, like, I thought it was staining for the cartilage.
No. It was after, it was a, how can I say that? After like processing. Yes.
Processing.
Yes. No staining. There are contrast medias or contrast materials, but to show, for example, an abscess in the next to the spine, but these are not for modeling purposes, but for medical purposes.
Okay, thank you very much. Very impressive talk. I really enjoyed your presentation. I actually wrote 6 questions, but I will ask you the main and important question that I had regarding the proximal junction kyphosis that you introduced it. I had a curiosity for other solutions, for other surgery solutions. I know that we already have some other solutions like using hooks and also using hardware density reduction. Do you think that the new tool, new fixation like PEEK or MRS are better than using the hook or hardware density reduction for post-conjunction kyphosis or not?
We don't know. Later it should be compared somehow with simulation or with clinical examples. My problem with the hooks that in compromised bone quality you can't attach the hooks to the lamina strongly. So sometimes we don't see proximal junctional kyphosis, but we see the loosening of the hooks from the lamina. On the other hand, the screw can be cemented into the vertebral body, for example, so the screw could be very strong, and that's why the vertebra above the final screw will fail. So these are different concepts, can work both.
I see people already with a backpack. It's because we have the visit to Barcelona Supercomputing Center. So don't worry, you can ask the food to take away. And then you can eat in the bus. So the bus will arrive at 2, and I will ask the driver, I will be there, I will ask the driver to wait until 2:15. So at 2:15, we drive away, okay? But you can take your food to take away and eat in the bus. Yes, Aine.
I have another question. And thank you very much. It was a very inspiring talk. My question is regarding the in silico or like virtual X-ray. It's very impressive to see that it performs this well. My question is, do you expect the fit to be worse for like more or different positions or like different patients?
Thank
because
you very
I expect
much.
if it's like...
Very important question. The picture, what I showed was an example, but the data and the analysis was the summary of 50 patients, 50 different spines in different degeneration process. Actually, if the paper will be, it's a good news for you. If the paper will be accepted, all the data set will be accessible. I didn't want to do that, but Peter wanted to do that.
Okay, great. So I think it's no time to...
Can I ask a final question?
Yeah, sure.
It goes back
ahead.
to the lady that you did 7 surgeries extra. Do you remember that you had a slide about this lady that there were like some follow-up of 7 surgeries? So I wanted to ask, did you do any analysis on showing how much money would you save from actually having an engineer doing a 3D finite element modeling before the surgery, so the system as a whole can save money from follow-up surgeries? Because I think that's the point in the end, alleviating the system from, do I put 3 holes, do I put screws, what do I do?
You're absolutely right. But the problem is that society and life work in another way, unfortunately. For example, for a hospital in Hungary, if a revision surgery is done 6 weeks after the index surgery, the hospital is totally reimbursed again. So forget the medical point of view and the ethical point of view. From financial point of view, if you have 6 weeks between the 2 surgeries, the hospital doesn't care about the patient because the hospital gets the new money. There are countries where the system is different and the hospital, we are in real economical trouble if the revision surgery should be done in shorter time than 6 weeks. But you are right, and this whole should be analyzed on the society level and on the governmental level. And in that case, and this is one of our goals, very shortly. There are cases when we have to remove the whole vertebral body or 2 vertebral bodies because of a tumor. And we have to replace with something, with some implant. There are different possibilities for the vertebra replacement, but one possibility would be the patient-specific vertebral body prosthesis. To produce that now, it's quite expensive because engineer, printing, and so on cost. But we will do a pilot project and we will try to show to the government that patient-specific prosthesis with better bone integration, better quality of life can give this money back to the society.
So, could we say, for example, that a startup right now could actually do this? That it will provide 3D models to the patients before their surgery, so they will go to the surgeons and they will say, oh, I did this outside of the surgery, so I want you to take this into consideration for them to know. It will not be provided by the system, it will be provided by individuals in the private sector, and they will just feed it. Could it be?
Can be.
Awesome.
I can tell you that it's not easy to have a certification for providing model for diagnostic purposes. It takes some years for a company, but it can be a good business model too. Yeah, I agree.
Some implant companies, I won't give any name, but are already thinking in that way and working on this kind of model. It can be good, it can be bad, future will tell. I think this very specific point is an excellent point for the digital bioethics roundtable we'll have on Friday. And so just keep it in mind if you have further questions. Aron, thank you very much.
Thank you very much.